Hello, ladies and gentlemen. It's my pleasure to give a talk this Stanley. I hope by next year I will participate this meeting in person. My topic that been assigned today is colorectal cancer screening in Thailand. Thailand is the country in Southeast Asia with the population of 66 to 70 millions. My topic today is based on four items. The first is colorectal cancer burden in Thailand. Second is who are our CSC screening barrier? And the third is what strategy should be used? And the last one, what is our future direction? According to our Thailand Cancer Registry that reported in 2011 and up to now, we found that colorectal cancer is the leading cause of cancer in male and the third one in female after breast and cervical cancer. As many of us understand, the adenoma carcinoma sequence is also applied for Thai population with the starting age of cancer around 60 to 65, 70 years. According to the screening program recommended by Minnesota Colon Cancer Control Study, they report that the annual FIT, fecal occult blood test, in this case we call fecal immunochemical test, can reduce the long-term colorectal cancer mortality. In addition to that, those who underwent colonoscopy and has polypectomy performed if a polyp was found. They show that by comparison to the expected from general population, the one who underwent colonoscopy has the lower incidence of cumulative colorectal cancer mortality. Therefore, in the US, the recommendation for colon cancer screening and in the interval is every 10 years if you choose to perform primary colonoscopy. On the other hand, if you choose to do FIT, you do it every 1 to 2 years and you proceed the patient to colonoscopy if FIT become positive. So there are two choices, two steps, FIT first or primary colonoscopy. And you can imagine this is the barrier we have to talk about. The Thailand is country of 66 million and maybe another 5 more million to the labor immigrants. So by rough calculation for those who are above 50 years, we are going to be the aging country. We have about 12 to 14 million population that require colon screening. Unfortunately, we have less than 1,000 endoscopists. So the shortage of endoscopists is the big factor. By looking at the health insurance, we have three systems. All of us who are Thai citizens will be covered by we call universal coverage. With this, you get generic medication as the treatment. Of course, you get the colon cancer screening, but usually we go with FIT if this thing can be reduced in terms of the financial burden. On the other side, those who under the we call Social Security Fund or government employee, which include about 40% of our population, this group of patients can select either primary colonoscopy or have it, FIT screening first. So at least 90% of Thai population being covered by this system. However, the big factor is the financial constraint, and another factor is the endoscopy personnel limitation. In addition, the incentive from reimbursement may be not directly to the healthcare provider because a lot of debt in the institution based or hospital. So many of revenue that generate from even we think endoscopy is a good business will go directly to this debt first. So the incentive of this will not be there because it's not go directly to the provider. So we have to balance about between the 12 million population workload. and the budget and the limitation of endoscopy capacity. So what strategy should be used? First, you can look at this benchmark, the one-time colonoscopy protocol versus every 2-year FIT. When you look at this, the difference in the value is there, but can we apply this to our country? What test should be used? Well, I think this one we followed the US president by saying that the best screening test is the screening test that gets done. Unfortunately, because of limitation, we said not all of us can do great things, but we can do small things with great love. I'm I'm sorry that this slide is written in Thai, but this is from the real number figure that they present in the government meeting. But you look at the blue highlight, showing that from these 14 million population who got screened with FIT, we calculate that the compliance of FIT could be around 70 to 80%. So at the end, we get about 91,000 cases to be screened by colonoscopy after positive FIT. So this is our workload there. However, if you chose to go directly as a primary colonoscopy, what is the cost and the price there? Well, the problem that we calculated, there are 9 more cases of colonoscopy workload per week and per endoscopist. The problem for us that many of us with limited resources, we have to do work in terms of endoscopy in those who come for disease based like upper GI bleeding, ESP for stone cholangitis, dyspepsia, this and that. So many of us may not be able to, we are extremely overloaded by this work. So 9 more may be something that not easy or not manageable by many of us. So if we choose, on the other hand, if we choose the subject at the age of 50 to 75 years of age, if FIT positive, we send patient directly to colonoscopy. If negative, you keep on doing it every 1 to 2 years, and then if positive, you send them to colonoscopy. So the test sensitivity, public participation, accessibility have to be harmonized. So we define the target population and catchment area by monitoring the long-term outcome adherent to screening. We need a lot of help from many of our team, not only doctor that can work on this, the data management team, the coder, the payer, the pathologist, endoscopist, nurses, family doctor. We have the villager, healthcare provider who can convince the patient to come and join the program. But more importantly, and the most important item is the patient who should accept colonoscopy of FIT as their screening test. So this is the the example of how we do in public. Many of hospitals don't have enough personnel to do endoscopy. So the team under the endoscopy society, went out and helped them promoting, and we call as the mass screening with about 8 to 10 endoscopy station and perform about 100 to 120 colonoscopy per day, including the treatment as like cholecystectomy, and we do registration and send the report directly to the government. So let's see from the one of the pilot example in one of northern province in Thailand, as you can see in the dark figure. For those who had received FIT kit, about 120,000 subjects in we call Lampang province. Interestingly, about 80 of them returned FIT. So in this case, FIT uptake rate was high, 63%, and about 876 subjects who got, at that time we used a cutoff as 200 nanogram per milliliter. So with a slightly low positivity rate of 1.1 because the high cutoff, 72% by figure, this number became 627 subjects underwent colonoscopy. And in this case, we found 23 colon cancer. So by calculation, this became 3.7%, with 75 advanced and normal 12%, adenoma 187 patient, and then this account test 30%. So basically, we calculate that number needed to screen is about 5,534. So the key of screening success are accessibility. FIT sensitivity is one of the things we have to talk, and we talk about more about compliance later. So by doing the quantitative FIT, we can, spectrum them into 25, 50, 100, 150, 200 nanogram per milliliter. And in this study, we enrolled about 1,500 participants who have both in terms of FIT negative or positive, and they all came from us. So we want to see what is a good average number to do that. By using different cutoff, as you can see, the AUC looks pretty good. And we found that, of course, you can imagine that the positive rate can go up to 25 nanogram to go down to 5% if you use a higher cutoff value. But interestingly, when you look at the negative predictive value, either for advanced neoplasia or colorectal cancer, it's still high. 92% in this figure and almost 99%, and only two colon cancer were missed if you use 200 nanogram per milliliter. You can see by this figure. So we then propose that, because we missed two colon cancer if used 200 nanograms, so we propose that the optimal cutoff FIT for limited colonoscopy capacity like Thailand should be 150 nanogram per milliliter. So with this, you have the sensitivity about 80% for advanced neoplasia and 80% for colon cancer. And the interesting thing that the number of colonoscopy workload will decrease to, if you compare to the lowest cutoff, to 87% and 94% respectively, as you can see by this formula. So the next important thing is the important screening tool on FIT. So what could be the future direction? The bottleneck is the capacity of colonoscopy. A lot of workload is there, as you can see in this figure, and the critical is, so we don't think one side can fit all. So we and the team in Asia Pacific, led by Professor Joseph Song in Hong Kong, found that what we call as risk score by go by age of the patient, the male gender, history of first degree relative with colon cancer, and smoking history. And later on, we found that obesity or overweight also would be the key factor. By putting this all together, plus FIT interpretation, and we can stratify the patient into 4 groups. The first group is the patient with high risk score. In this case, it's more than 7 and with positive FIT. Second group is patient with high risk but negative FIT. The third group is the patient with average risk and positive FIT. And the last group is patient who got negative FIT and average risk. So by having all of them underwent colonoscopy, we found that the advanced adenoma, in this case, with high risk and positive, we found the highest percentage of advanced adenoma, almost 37%, compared to the group who got negative and no risk factor is only 6.4%. So the other two who got either high risk by calculation or have FIT positive, but in the average risk, we got about 12% of advanced neoplasia. So it's quite amazing that if you have limited resource, you can prioritize the type of patient who need to be screened first. Okay, so to get bigger picture, we use the same protocol in terms of bigger population. In this case, we have about 16,000 population, and also we perform the same thing. Interestingly, that if you look at this risk patient, if you use the high cutoff, you may miss cancer or advanced neoplasia. So in this case, we lower down the cutoff for FIT, and with that, by using appropriate, we call by lowering down the FIT for CSC screening in high-risk subjects, we could improve screening performance by reducing the unnecessary colonoscopy and to maintain high sensitivity And specifically for advanced neoplasia, the optimal cutoff in the high-risk subject should be lower than that of in the average risk. This is our conclusion. In addition, at the lower S cutoff, the number of needed colonoscopy to find one advanced neoplasia was 2.8 and 6.1 for the high risk and average risk group respectively. So the next key point is selecting and prioritizing the highly subject may be useful. So in this regard, we have come up with the idea in terms of patient selection, the strategic protocol, and the tool and the budget plan. However, we still have a lot of room for improvement to customize our own strategy. We use our budgets wisely. The problem is the limited incentive, the equipment to monitor adherence and outcome. However, with health awareness, together we can. Thank you for your attention.